I am Dr.K Gireesh, physician, neurophysician and neurosurgeon. I am delivering this talk, health talk, for the awareness of the general public as well as the medical fraternity. This is a part of the continuing medical education program that is being organized by Padma Clinic and Nursing Home, 753 Punamali High Road, Chennai, as well as Lions Club of Madras Excellence, District 324K Lions Clubs International, as a part of their health awareness program. Today, I will talk to you on the clinical features of Parkinson's disease, a disease that has been described by James Parkinson in the year 1817. He described it in about 6 patients whom he saw a uniform feature which included tremor, rigidity, bradykinesia or akinesia and postural abnormalities. We will go into each one of these into minute details. The manifestations of Parkinson's disease are numerous and complex. The classical syndrome, when present, consists of 4 cardinal clinical features: tremor, rigidity, bradykinesia, slowness of movements, posture, and the gait abnormalities. Most of the motor signs of Parkinson's disease represent variants of these 4 cardinal features. The disease is usually unilateral at the time of the presentation and may remain confined to one side for many years and progressively worsening before becoming bilateral. In its typical form, the diagnosis of Parkinson's disease is not difficult, but not infrequently the presentation becomes a little atypical. All patients may not have all the 4 cardinal signs of the disease at the onset. The symptoms are very slow in onset. Many patients are aware of its presence until the tremor appears. The first symptom that the patient usually complains of is a tremor of one hand, spreading after a variable period of months or years to affect the other hand, the legs or the face. The characteristic tremor of Parkinson's disease affects about 70% of the patients. When the tremor is not the presenting symptom, bradykinesia is first recognized. That means a slight slowness of movements will be there, or arms swinging when walking will not be there. Muscle rigidity is almost always a manifestation of Parkinson's disease. In some patients, the symptoms may be vague. The muscle power, tendon reflexes, and the plantar responses are generally normal. Movements of the hand are clumsy, and the fine movements, it will be very difficult, especially handwriting. It becomes progressively small as the disease increases in severity. Fatigue, tiredness is a common complaint. Numbness and pain without demonstrable sensory loss are also seen in Parkinson's disease patients. Sometimes the initial presentation may be a little discomfort in the limbs and difficulty in walking, a stiffness of the limbs and so on. Now let us go through each one of these: tremor, rigidity, bradykinesia and postural abnormalities. Let's see the tremor. Tremor is classically referred to as a resting tremor, and when the patient has some activity, the tremor disappears. So it is classically referred to as a resting tremor because it occurs while the patient is at rest and just get increased by stress and disappears by goal-directed movements during sleep. And also interesting, the tremulous limbs was noted by James Parkinson. Approximately 70% of the patients present with tremor as the initial symptom. Almost all patient experiences this symptom at some time during the illness. So, tremor is an integral component of Parkinson's disease. Sometimes it may be of the jaw or the tongue, and rarely you find isolated leg tremor will occur. Although the tremor is commonly unilateral when it begins, it invariably becomes bilateral with time. The hand which is most affected assumes a posture of flexion of the metacarpophalangeal joints and extension of the more distal joints. This is in fact seen in Parkinson's disease with tremor of long duration. And the presence of tremor in the finger makes it appear as if the patient is rolling a pill between the thumb and the index finger, and hence the term the pill rolling tremor. This is exactly the classical tremor that occurs, the pill rolling tremor. The restrained tremor in Parkinson's disease is rhythmic and alternating in nature and has a frequency of 4 to 6 Hz with harmonic resonances and fine tuning. Tremor is an unsettling symptom since it is a highly visible phenomenon and may carry some emotional instability of the individual. It is frequently more embarrassing to the patient than disabling, particularly in the early stages of the disease, and it worsens with stress or heightened emotions. The other symptom is the rigidity. Rigidity is present in almost all cases of Parkinson's disease. The examiner encounters uniform resistance throughout the range of the passive movements, equal in agonists and antagonists. Now, when you ask the patient to flex like this and ask him to extend, and then you touch the biceps, you can see like this a jerky movement going on in the biceps. This is called the plasticity or the lead pipe rigidity. The combination of tremor and plastic rigidity with the tremor temporarily and repeatedly interrupting the rigidity gives it a ratchety quality, and thus the term the cogwheel rigidity. The cogwheel effect is characterized by bursts of activity in the stretched muscle at a frequency about 8 Hz. Initially, the rigidity may be mild, restricted to a few groups of muscles, but later on it progresses to involve the whole body. Rigidity contributes to the limited range and slowness of movements that characterize Parkinson's disease. Although James Parkinson did not mention in his essay on shaking palsy in 1817, rigidity is now accepted as a characteristic feature of the disease. It can manifest in patients as muscle aches and stiffness, frequently in the neck and the back, and also it can be generalized. The third component is the bradykinesia, the slowness or the poverty of movement, with loss of the automatic stereotyped movements. For example, when you walk, you might swing your hand like this, both hands. That becomes less. One side, the side where it is affected, you keep your hand like this and walk. It is perceived by the patient as a slowing of his ability to perform the usual activities of daily living, like this bathing, dressing, rising from a chair, turning over in the bed. All these movements becomes very, very slow, including buttoning, unbuttoning, shaving and similar activities. Hesitation on the initial movement is another very important feature of bradykinesia. And the face becomes a maskless, there's a masked face, expressionless face, and subsequent loss of the blinking, an absence of arm swing when walking, small cramped handwriting, the soft monotonous speech, decrease in the frequency of swallowing, an accumulation of saliva in the mouth, and drooling occurs. These are all some of the features of bradykinesia, the slowness that muscles, or you can say, started exhibiting. James Parkinson did not describe the masked face in his original essay. It was subsequently recognized by Charcot and other common manifestation of Parkinson's disease. The lack of expression of both sides of the face will be there. Sometimes the face is fixed in a vacant smile. The eyes are moved reluctantly. When there is a unilateral involvement of the limbs, masking may be limited to the corresponding side of the face. These are some of the observations, the clinical aspects of Parkinson's disease. Next, and the fourth component is the posture and the gait abnormalities. The posture of the Parkinsonian patient involves flexion of the head, trunk and extremities. There will be a flexion. It is stooping, what you can say, forward, and you will be walking like this. It is to catch the center of gravity. The truncal flexion is often severe, and the patient usually lean to one side even when sitting. He will be sitting like this. The loss of postural reflexes often results in poor balance. If the patient encounters even minor postural perturbation or disturbance, a slight push and he will fall. The normal protective mechanisms associated with falling are all lost in the Parkinsonian patient, thus rendering him or her unable to do anything to break that fall. I have had a patient whom I have been advising, you be very careful when you walk, because you'll be moving forward, running what you can see to catch the center of gravity. So be careful about it. So when you get up and when you start walking, be extremely careful. In case if you essential, you have an assistant or assistants for that walking. But sometimes they feel they are all normal and they get up and suddenly they lose their balance and then they fall down, and this particular patient developed a fracture neck of femur. The gait in Parkinson's disease is abnormal. In addition to the postural abnormalities and the loss of arm swing, the Parkinsonian patient generally takes small shuffling steps. Difficulty in beginning to walk can occur in certain places you call as, once started, they lead to a festering gait. So initial hesitation, called sometimes freezing, you call it, as a complication of a long-term administration of syndopa, that can occur, or festinating, they keep on hurrying like this. It is to catch the center of gravity. In the original description of the disease, there are some other features other than these four components: tremor, rigidity, bradykinesia and postural gait abnormalities. There are some other abnormalities also that have been noticed in the original description of the disease by James Parkinson. Interruption of the speech. Speech becomes unintelligible. You get the slurring of the speech. The articulation is slow and the voice, hypophonia or dysphonia occurs. The voice will not be much audible. That is another very important. The tune of the speech also will actually go off. So this is again very, very important. Other motor and neurobehavioral abnormalities also have been noticed in these patients. Depression is another one, maybe as a consequence of the disease or even as a part of the disease. It is associated with the decreased turnover of serotonin. Gastrointestinal disturbances can occur as part of the disease or because of the medicine that is being given. Most important is constipation. Weight loss is also very common and sometimes severe. Approximately 75% of the patients are below their optimal weight. Urinary difficulties such as irritable bladder with frequent urgent incontinence can also occur. Prostatic enlargement is also very common in the elderly males, and that can contribute to the overall problem. Some autonomic features also can occur, like excessive sweating, seborrhea of the scalp and forehead are very common. And some patients develop orthostatic hypotension unrelated to the drug therapy. That is, when they get up from the sitting to from the lying down to the sitting position, the BP falls, and that is orthostatic hypotension. Mild abnormalities of eye movements also known to develop with progression of the disease, maybe an upward gaze or a sparing of the downward gaze, blepharospasm or some things can occur very rarely. Slowness is thinking is actually another feature that can occur. Again, it is in fact a part of the bradyphernia. Sensory symptoms like numbness, coldness, burning sensation and pain can occur occasionally, and sometimes it may be severe with Parkinson's disease. Akathisia, an urge to move, that means a restlessness, might be another feature of Parkinson's disease. These are the associated features. So, the commonest features are tremor, rigidity, akinesia or bradykinesia and postural abnormalities. That is why TRAP is the acronym used for. T, tremor, R, rigidity, A, akinesia, P, postural abnormalities. Hughes et al. Published actually in the Journal of Archive Neurology in 1993 has said, a change in the facial expression, failure to, these are some of the very earliest symptoms. There are some early signs and symptoms of Parkinson's disease. Before even you find the tremor, rigidity, bradykinesia and postural and gait abnormalities occur, you find some early signs are there in Parkinson's disease. What are they? They have studied that Hughes and co. as well as Schiffel and co. in fact has studied all these and they have put it up. Their observations, which has been published in Acta Neurologica Scandinavia 1995 as well as in Archives of Neurology 1993 by Hughes and team. Change in the facial expression, a staring look, a lack of blinking. This may be one of the very early manifestations of Parkinson's disease. Failure to swing one arm when walking. You find one arm will be less swinging. Flexion posture, a stooped posture, is one of the signs that Parkinson's is to start. Frozen painful shoulder is yet another manifestation, an early manifestation of Parkinson's disease as observed by Hughes et al. Limping or dragging of one leg, that is another manifestation, early manifestation. Numbness, tingling, aches or discomfort of the neck or the limbs. This has been again noticed in some of the patients prior to the onset of Parkinson's disease. Softness of the voice, subjective sensations of internal trembling. You may not find anything outside, but you feel there is a trembling inside your body. You see, like a fever with rigor, like that you get a tremble inside the body. These are some of the earliest manifestations of Parkinson's disease, like change in facial expression, failure to swing one arm when they walk, flexion or a stooped posture, a frozen painful shoulder, limping or dragging of one leg, numbness, tingling, aches or discomfort of the neck or the limbs, softness of the voice, subjective sensation of internal trembling or resting tremor. These are some of the early signs and symptoms of Parkinson's disease. As pointed out by Hughes et al. In the Archives of Neurology 1993. UK Parkinson's Disease Society of Brain Bank has recommended that following are the features suggestive of Parkinson's disease. It's very nice. They got step 1, step 2 and step 3, of which step 3 they clearly delineate, supportive, positive criteria for Parkinson's disease. 3 or more required for the diagnosis of definite Parkinson's disease. They are unilateral onset, resting tremor is present, progressive disorder, persistent asymmetry affecting the side of the onset most, and excellent response 70 to 100% to L-DOPA and severe L-DOPA induced chorea. Levodopa response for 4 years or more, clinical course of 10 years or more. That's very important. So therefore, you find 3 out of these criteria, if it is there, it is more definitive of Parkinson's disease. However, James Parkinson has described this in 1817. And today, of course, with respect, we can actually diagnose fairly, the DOPA scan can be taken. However, until prior to that, we have been diagnosing only Parkinson's disease at the bedside or in an outpatient clinic. As the patient walks into, we just see tremor, rigidity, bradykinesia and postural abnormality, and we diagnose that this is Parkinson's disease. So that's indeed in brief on the clinical features of Parkinson's disease.